Hi, everybody, and welcome to today's second part of our special two-part series in sexual health and recovery. Today, I'm joined by my colleague, Jen Sperduto, and although I'm going to be leading our chat today, Jen is going to be paying attention to the actual chat box and any kind of questions that come in, and she will help us out tremendously, as she always does. We're a gruesome twosome team here. Yeah. So welcome. We are both from Rutgers University, and today we'll be talking about this. We'll be covering the second half of a discussion around sexual health and recovery. So just some housekeeping. Today's webinar is hosted by DBHR through the Healthcare Authority. This is an interactive training, and we encourage you to ask questions. Sorry, I'm looking for the closed captioning before anybody has to ask. There we go. This is an interactive training, and we encourage you to ask questions and interact throughout this session. I like to talk, but I don't like to talk too much, especially at the end of the day. So anything that you have at end of the day for us, sorry, it's 5 p.m. here on the East Coast. Any kind of contribution that you might have to the chat, please don't hold back. Feel free to volunteer. Any questions, comments that you may have, and just be aware that this is being recorded. Not that anything that you say can and will be used against you, but just letting you know that it is being recorded. The slides, as well as that link to the recording of the webinar, will be available in a follow-up email after this presentation. And you'll be able to watch that and share it with anybody that you might want to share it with. So additional housekeeping items, everyone is muted upon entry and your cameras are off. However, to ask a question, you can open the chat and say that you have a question. Alternatively, you can type your question in the chat box, or you can raise your hand from the participant list and Jen will unmute you. And again, feel free to ask any questions as they arise. You don't have to wait to the end because very often we run out of time. So please feel free to contribute as you would normally do in conversation mode as the presentation is going on. Also, I would like to say that there may be folks in the audience who have a lot of information to offer to this topic in terms of training or experience that you may have had with your particular clientele or specialized trainings that you have attended or life experience. And so I welcome that contribution. All right, I'm going to briefly say that I've worked in the field for a very long time. Most of that time, was in supportive housing and homeless street outreach. And working with individuals who had co-occurring mental health conditions and substance use conditions. And for about the last 7.5 years, I've worked with a team of embedded consultants with the New Jersey State Psychiatric Hospitals to provide training, consultation, and program evaluation on evidence-based practices in those settings. And I'm going to say almost ditto for Jen. Jen has a bunch of years of experience in the mental health field, in community mental health, in recovery-oriented programming, and she shares the role that I share with also, which is to provide technical assistance, consultation, and training to our state hospitals on behalf of the university. So with all that housekeeping taken care of, let's go ahead and get started and look at what I hope you'll be able to express at the end of this training. And so that is, we're going to define sexual health. For those of you who were here last Wednesday and attended part 1, that part's going to be a little bit of a review for you, but it's probably going to be about 10 minutes. So sit back, relax, and know that you got this stuff already. So we're going to briefly review what we mean when we talk about sexual health. For our purposes tonight, we're going to be talking about special population and how that special population faces increasing challenges, or I should say increased challenges, due to something that we call intersectionality. And we'll talk a little bit about that We won't spend the bulk of our time talking about that. What we will talk more about is just understanding and differentiating what we mean and what others mean when they talk about gender and affectional orientation. And if you've not heard the term affectional orientation, it was previously referred to and still is referred to as sexual orientation. But we're going to talk a little bit about why that term sexual orientation may not be as all-encompassing as it needs to be when we talk about who people are attracted to and choose to spend their time with and or be sexually intimate with. We're also going to look at strategies for supporting people in their sexual health journey. And whereas that part is not going to be specific to gender identity and some of the and affectional orientation and the stigma that and intersectionality that individuals can face if they're part of the LGBTQ plus community, we're going to talk more about how to talk to people about sexual health topics. We're going to use a specific example around sexual safety while engaging in sexual activities, and how we can use therapeutic strategies such as motivational interviewing and understanding where people are in terms of stages of change to use as a blueprint for having those difficult conversations. And using those strategies does not have to only be confined to sexual health. Motivational interviewing and understanding where people are in terms of their readiness to make changes around behaviors that may be potentially risky to them, or simply just behaviors that they want to improve upon, or goals that they would like to achieve, how that kind of approach can be helpful in some challenging situations like behavior change, which can be very challenging for all of us. Okay, so as I said, if you were here last week, this slide looks familiar to you, as will probably the next 2 or 3. But I bring this slide up because I want to ask you, and maybe I should have left off the love, support, and growth off of here. But when you think about, and I'm going to say it says sexual health here in the upper right-hand corner, but I want you to kind of like block that out. That probably shouldn't even be there. When you think about intimate relationships with or without sex, and that's why I say maybe sexual health shouldn't be up in that corner because it's a trigger for a lot of people. They immediately think about sex. When you think about intimate relationships, whether they're close friendships, whether they are romantic relationships where there's like romantic feelings and feelings of love and affection that go beyond platonic or familial, what are some of the thoughts that come up for you when you think about perhaps a very healthy, positive, romantic or romantic, intimate relationship that either you've had, that you've seen modeled for you? What are the things that you feel like come with that type of relationship? And for me, those things were love, support, and growth, right? I see a relationship that is positive and a healthy, intimate relationship as one that obviously, hopefully it's in this medium of love, right? The overall affection, or not overall affection, but overall feeling of love, it's framed in love. But that also there's a support, there's a person or persons, if we're talking about, alternative type relationships, or if we're even talking about family and friends, right? Again, an intimate relationship may not have to do with sex, but sharing of feelings. So what are some of those things that these types of positive, healthy relationships offer us? For me, support of others, knowing that people understand my goals. We probably share a lot of value sets, right? And that's very important. And that they might challenge me to grow in that relationship. What do others think? Hey, so we got a super secret message from one of our participants, and that was communication, trust, and honesty. Yeah, I love it, right? And there's no right or wrong answer here. So absolutely, communication, trust, and honesty. And that can be challenging, especially if, look, we all come into this world pretty much a clean slate with the exception of our genetics, right? And a lot of things can happen in our early childhood and within our environment that can kind of test our ability to make really secure attachments to people. That's another training I'd love to do about attachment styles. But so there's a lot of things that can really test our ability to trust in others and to communicate openly without fear of being criticized or rejected, right? And being in that type of open or intimate relationship can help with that. Hey, I think, did I see more? Nope. Okay. So thank you. So if anybody else wants to, oh, I think we have another one. Harmony. So somebody else said harmony and being in sync. I love it. Right. So, and when I talked about like the person understanding what my goals are, what my values are, and understanding his or her role in supporting that, whether it just means giving me some time to pursue my goals, or whether that means, you know, we're traveling down that path together. Absolutely. Okay, thank you to those of you who offered your feedback. I appreciate it. So I just want you, the reason for this little bit of a thought exercise is just to get you thinking, and I'm sorry I'm using my hands a lot. It comes out when I'm not feeling well. My jersey really comes out, and I'm having a COVID scare right now. So sorry. I want you to think about, and I challenged the folks in last week's training also to think about, you know, what it is that healthy romantic relationships have done for you in your life. And again, I say healthy because I'm sure we've all had experiences, or many of us have had experiences, I'm sorry, with the opposite of healthy, or at least tumultuous. So think about that as we discuss things tonight or this afternoon for you all. And think about how we probably should want, I think we do want, all of the individuals that we work with and advocate for and support to have those things as a part of their life as well. And how those things can help support psychiatric recovery rather than requiring people to be symptom-free and doing all the things that we expect them to do or that we think looks like functioning well in the community before they're able to give and receive love. And that giving and receiving of love and support can really help in a recovery process. And I do want to pause there and mention that we did have somebody, I think we had a couple people in the training a week ago bring up that, isn't that in conflict, that idea that it's okay and that it should be encouraged for individuals to have romantic relationships, to date, to search out new relationships when they're early in recovery, especially from substance use, right? One of the recommendations in 12-step groups, which I've not been a part of, but I understand from my work in the field, is that individuals do not enter into a relationship in the first year of sobriety. There are alternatives to NA. There are alternatives to 12-step programs. And that may be a great suggestion and solution for an individual. It may not be for another. So I think that's one of the things that we need to understand, is that one size doesn't fit all, that one person's method of recovery may not be the path for another. And so for some people, not having love and romantic love in their life can be very detrimental to their mental health. Thank you, Oliver. Exactly. There's many. Yeah. So Greg, so tell me more if you can. I frequently hear it from individuals who attend 12-step meetings or facilitate it. So perhaps that's a recommendation and not a policy. And again, like, nobody can tell a person, you know, a 12-step program isn't necessarily a formalized treatment program. And even in formalized treatment programs, one cannot dictate how another individual is going to recover. So I'm curious, Greg, where people got the idea that it should be a mandate, because I hear it all the time. And it comes up in a lot of our trainings. Treatment. Yeah. Thank you. So yeah, and that's, in the world of psychiatric treatment, behavioral health services, substance use services, substance use related services, or I should just say, dependency services in general, because it may not be limited to just substances. We have a lot of these thou shalt nots. And I know that when I entered the field almost 24 years ago, I had a lot of my own, and it came from inexperience. And I was just kind of like following the lessons of the people around me, right? The people who came before me, the people who were teaching me on the job how to really do this job. And what I found out was not all of their advice was good. Not all of it was recovery oriented. And I had to unlearn a lot of that. And so I thank you for your contribution. So let's define sexual health. Again, this is a refresher for those of you who were here last week. So sexual health is fundamental to the overall health and well-being of individuals, couples, and families, and to the social and economic development of communities and countries per the World Health Organization. And I think that we can easily understand at least part of why, right? Even if we just simply look at the disease transmission risk issues, and other family planning issues, we can see how, not having an informed populace or public can contribute to significant issues for families, for communities, for countries, right? If you have seen countries that are ravaged by sexually transmissible infections such as HIV, you could see it can essentially eliminate almost a generation of people, right? It can take a lot of people out of the workforce. And this isn't just limited to, the heavy hitter diseases that we think about, but, not being literate on sexual health can have a detrimental effect to communities and not just the individual. And so sexual health is a broad topic. We're not just talking about sex. We're talking about all of those other things, those bio, psycho, social, environmental things that influence our overall level of sexual health. And so some of those things include, sexual health actually, it requires us to have a positive and respectful approach to not only sexuality, but sexual relationships and the forms that they take. Understanding this could have conflict with individuals' religious beliefs and spiritual beliefs, and that's okay. As long as we continue to, for the general populace, continue to address sexual health concerns. We also are concerned with the possibility of individuals being able to have pleasurable and safe sexual experiences. Not having the ability to be afforded pleasurable and safe sexual experiences can contribute to poor mental health, and can also contribute to other issues such as dependency issues. Individuals should be free of coercion. So sexual experiences, we need individuals to understand consent issues around consent, when consent takes place, that an individual can stop a sexual act or should be respected to have a sexual act stopped when asked, even if it's already been initiated. These are things that we're talking about when we're talking about like those bigger issues around sexual health. And also free of discrimination and things like sexual assault and intimate partner violence, or also what may be considered more broadly as domestic violence. Okay. So today, you see the slide here. We had the slide up during the last week's presentation when we talked a bit about how stigma can segregate individuals who have behavioral health conditions, may have other co-occurring conditions, and intensely be increased that feeling of stigma, and sometimes internalized stigma when there are additional characteristics about the individual for which society has historically ostracized them, okay, or ostracized us, or, it depends on if you're part of that group, right? So those characteristics for which people were pushed to the edges and out of the mainstream of society, and very often targeted and looked down upon. So think about when the AIDS epidemic hit in the early to mid 80s. And there was specifically one group of people who were targeted, who were stigmatized, and who were primarily blamed for the disease transmission of HIV, right? When you fast forward to now and you look at groups of individuals who are transmitting HIV, it looks much more flat, I would say, in that we now know, right, that HIV is an equal opportunity threat. Yes, there are certain populations that may be more vulnerable, but we are all vulnerable to sexually transmitted infections such as HIV. It does not discriminate. So, and that stigma at that time really hurt the LGBTQ population, specifically or primarily gay men at that time. And there's a lot of, and I don't know this to be fact, but there's a lot of debate on the whether assistance was rushed as quickly as it could have been because of the population that it was assumed that this condition was primarily affecting, that being a gay male population, right? That was already stigmatized and devalued. So when you consider that there are certain characteristics of individuals that have already been devalued in society, and then we layer a mental health condition upon it, we could see how that stigma can be amplified. In addition to stigma being amplified coming from the community and from society and media in general, what can also occur is an internalization of that stigma. So sometimes those messages are so strong, individuals can adopt them and assume what we call an illness identity, or I don't want to say damaged goods, but the kind of like the shattered image of what the individual actually is, right? These negative self-talks that we have with ourselves and these labels that we start to affix to ourselves. I'm a mental health, or I'm a psychiatric patient. There's reasons why we don't use the term patient very frequently when we're talking about individuals receiving psychiatric services, because of the stigma that surrounded being a quote unquote mental patient in the past, right? And I'm sorry if that sounds offensive, but I said it for a reason, because it is offensive. Because in the past, people were written off when they interact with the mental health system in any way. And that's why we need to be really careful about language. So in addition to maybe having a characteristic that an individual, may not identify with their assigned sex at birth, in terms of their gender identity, that puts them in a different group, a particular group, right? And then we also may layer on a mental health condition, and that adds to it. So we're really talking about like this compounding stigma and compounding barriers that people can then face, sometimes internally more so than even externally. So some of the things that we need to do to ensure that we can achieve sexual health is that we have access to comprehensive and good quality information about sex and sexuality. That's why we're talking today, to get out some basic information so you can be better prepared to interact and engage with the individuals that you work with around sexual health issues. Just be more comfortable with having those conversations, because they're not easy. We need to have knowledge about the risks that are faced and vulnerability to adverse consequences of unprotected sexual activity. So we need, as professionals, to start recognizing risks that our clients, that our service recipients, that our partners face in the realm of sexual health as just as risky as any other health-related threat or condition. ability to access sexual health care, I'm sorry, and to be ensured that we live in an environment that affirms and promotes sexual health. And that's part of also what we're trying to accomplish with this talk, is just to get you all, and I continue to get more comfortable every time that I have one of these talks, comfortable with having conversations. Because as mental health professionals, as behavioral health professionals, we are always told to keep those boundaries strong, right? And to keep boundaries firm. And sometimes I think to the detriment of having hard conversations with individuals that we serve. And I'm just going to pause here for 1 minute before I really talk about this slide. There is overwhelming research from about the last 15 years of research into sexual health. There's been a lot of research in the last 10 to 15 years. And overwhelmingly, individuals who receive behavioral health services say that their sexual health is one of their major unmet needs. They also say that they want the individuals who provide services to them to talk to them about this aspect of their life. However, on the flip side, when individuals providing services are surveyed, they feel unprepared, or they feel uncomfortable, or they feel as if they might be crossing the line to have one of these conversations with their service recipients, or that perhaps they're not the well-qualified person in the room to have the conversation. And I want you to think about, if you're in the role of, say, something equivalent to a case manager, a housing specialist, a support worker, you don't have the answers to everything anyway. I know I sure as heck didn't when I was a case manager, or when I was a residential counselor, or heck, even when I was the director of a program. But what you're expert at is helping to advocate, helping to educate to the extent that you can, and referring and linking and supporting individuals to those affirming services. And I don't mean just gender affirming, but sexual health positive affirming services that are available. So just please keep that in mind, that people want assistance. It's kind of like we need to figure out how to provide it. That's kind of where the gap is. So when we talk about gender, and the next several slides, most of the rest of this is going to be talking about some of the language and terms that are used when we talk about gender and affectional orientation. And so if you know this, great. Please don't be insulted that I'm talking like it might be the first time you've heard it. I assume that probably at least half the people in this room are pretty well versed. But please feel free to share this with other individuals who you feel may need additional support and training, if that's the case. So when we talk about gender, a traditional definition would be either of the two sexes. So when we think about sex as biological sex, male and female, what we also know is individuals could be intersexed. And so individuals who are intersexed, this is not the same thing as being transsexual or transgender. They are very different things. An individual who is intersexed is born with complete sets or partial sets of each sex's reproductive organs. So they may be born with, they may present as both sexes in terms of their reproductive organs: vagina, penis, testicles, perhaps, maybe an ovary, and there could be combinations of the both. But when we talk about gender, what we're really referring to are societal concepts. These are social and cultural constructs, and there's differences between the traditional male and female socially constructed gender roles, right? What have you guys heard about men? What's a socially perpetuated
loaded question, Dawn?
Oh, I'm sorry. Yeah, I'm sorry. Let me pouch that in. What does society say men are like? Be nice, ladies. Be nice. Be nice, ladies and gentlemen. Be nice. or women. You pick on women. That's okay. You can pick on women too. I'm a good sport. Unemotional, right? And what are women? What do they say about women? Emotional, right? It's usually the flip side. It's usually like the other side of the quarter. Yeah, they're focused, they're dominant, they're overly rational, they're not leading with their heart, they're leading with their mind. Yeah, closed off, assertive. Right, Jen. So like they're the leaders, right? They're strong. No, you're not, Monty. Not pigs or dogs, not at all. Maybe puppies. Puppies? Maybe puppies. Kidding. Right. So, and females, right? We might say emotional. I don't know. Weak. Sensitive. Oh,
Sensitive, aggressive,
sensitive, aggressive, moody. Thank you. You on any given day. Thank you.
violent, submissive. Men are violent, women are submissive, I'm assuming.
Probably. Yeah. Yeah. So the flip side, right? Yeah. So great. So you see, and how many of us have met? I mean, I think all of us use, I don't know if I want to say stereotypes, but they are stereotypes. We use these things to kind of like categorize people and make quick judgments about them. And it's not always helpful, right? Especially in relationships. This isn't always helpful. And in just being friends and understanding other people, it's not fair to just assume that because someone's a male that they're violent. If somebody's a female, they're going to be submissive or moody, right? There's a lot of stereotypes out there. So, but increasingly, as we become a bit more educated and understand that, we're not always submissive as females, right? I might be seen as submissive at times when I just prefer to take the step back and listen before I interject and go off. It doesn't mean I'm allowing somebody to talk over me. It doesn't necessarily mean that I am bowing out, that I'm not participating in the argument. I'm preparing. I'm doing it strategically, right? So these things may not always pan out to be true, and often don't. But also, we can pull on what are traditionally considered more masculine traits as women when we need to, right? And men will pull on what are considered more feminine traits when they need to. And, I hate that they're labeled that way as male or female. I think emotions and behaviors should just be on a continuum, right? And that's kind of what we think of now when we think about gender identity, is that folks, just like with sexuality, very often people tend to fall on a continuum, right? Like with sexual, or what is now dubbed affectional orientation, an individual, let's say I may find a female attractive, but I may not have urges to act on that in like a romantic or sexual way. So that may put me somewhere further along the line of, what would traditionally be thought of as homosexuality than somebody who can't see another woman as sexually attractive, right? So we tend to all fall somewhere along a continuum. And the same can be true for gender if you think about it in terms of the societal constructs. So it denotes a range of identities that don't necessarily correspond to established ideals of male or female, and also do not necessarily correspond with one's assigned sex at birth. And when I say one's assigned sex at birth, I mean the presentation, their biological presentation that was expressed at the time of delivery, right? So the parts that were there is basically how doctors determine this is a boy baby, this is a girl baby, those parts. It's not taking into consideration how the individual actually identifies as they begin to grow and learn and kind of understand their preferences, what comes to them innately, and the individuals that they may be drawn to. So this is one's gender identity is their personal sense of having a particular gender. So this is where the mind starts to come into play, right? So we're moving beyond that biological expression of sex to how that individual identifies. And those, we'll talk about how that expression takes place. And so when we talk about transgender, and it's not transgendered, it's not something that's done to somebody, and I've made that language mistake, and I was corrected for it, and rightly so, in front of others. Transgender is the gender identity that is not fully aligned with the assigned or biological expression of sex at birth. So that is all that means, that what was assigned to the person on their birth certificate isn't aligned with how they feel. So there's a few other terms that I'd like you to know if you don't already, and those are things like gender expression. So gender expression is how one chooses to express themselves to the world, how one chooses to present their gender identity, who they are, who they identify with, how they identify to the world, right? And so again, when we look at, you can't always judge a male gender identity versus a female gender identity, or a fluid identity based on how an individual is necessarily dressed. So consider, and a lot of this is because of shifting societal norms. Consider 50 years ago when my mother was in, we'll say high school, because I'm not that old yet. When my mother was in high school, she wasn't allowed to wear jeans until her senior year of high school. Girls were simply not allowed, right? They had to wear dresses or skirts because it was deemed inappropriate for women for whatever reason. And that has since changed. Likewise, males can express themselves with what are considered more feminine clothing, and it's become more acceptable. And I see a few things in the chat, and I just wanted to. Oh, okay.
Yeah, it's okay. We were
okay.
Somebody was saying that sometimes like it's not the things don't always fit the stereotypes, right? Like sometimes there's men who are very feminine, sometimes there's women who are the stronger leaders, and of course there's the fluidity that you don't have to go into those boxes.
And thank goodness we can kind of float, right? In terms of what skills, what behaviors, what kind of thought processes we need to switch into at the moment to take care of what we need to take care of. Right. And we can't fit people into boxes because of that. So when we talk about, or when you hear people talk about gender presentation, what that means is how the world sees or perceives an individual or us, right? So based maybe on the fact that I'm wearing lipstick, based on the fact that maybe, I don't know, well, nothing else that I'm wearing today is very feminine, but based on the fact that I'm wearing lipstick, maybe a person assumes that I identify as female. I also put on lipstick today. I don't always wear lipstick. I put it on because I've been sick and my lips were a little pale and bluish. It didn't have a whole lot to do with wanting to appear more feminine as much as I don't want to appear like I'm dying in front of all of you. So again, like understanding that gender presentation can also be affected by the interpretation of the other, right? The society and how the world or culture interprets us. So it's viewed through that societal lens of gender social roles, just like I said, lipstick, female. Well, not always, because I sure remember a lot of glam rockers in the 80s and 90s who wore much more makeup than I've ever worn my entire life. And were identified as males, right? I had a gender identity of male. So we can't always assume that. But I also remember the digs that folks, especially in older generations, had about those bands that had the big hair, the Bon Jovi bands, right? Skid Row, the big hair. Sorry if there's young folks in here who don't know who Skid Row is. the big hair, the makeup, and all that stuff. So those societal lenses do tend to change over time. Unfortunately, not everybody's bigotry changes at the same rate. So I'm just going to say that. We are dating ourselves, Jen. Thank you. Gonna have to listen to some big hair rock later. So some common gender identity terms that you may hear and may have questions about. I'm going to start out with cisgender. So if you've ever heard cisgender, what this means is that the gender that you identify with aligns with your biological or assigned sexual expression at birth. So you have a vagina and you have ovaries and you identify as female, for instance, as an example. I just saw your comment, Monty, so rock on. There's another term called non-binary. This is kind of an umbrella term that several other terms could fall under. Things like gender fluid may fall into this category. Somebody who may not necessarily identify with either one gender or any one gender all the time. Some individuals identify as agender, not belonging to any specific gender, and so on. And so you will sometimes see that as an umbrella term for an individual who may not identify with one or the other. And then we have transgender. So we touched on this earlier. This term you're probably most familiar with in terms of these gender identity terms. And that is an individual whose gender identity is not aligned with the sex assigned at birth again. So someone who may have been assigned female at birth on their birth certificate because of their sexual organ expression, but identifies as male or as male. And I also included and individuals on the West Coast, especially in the Pacific Northwest. I know that you have a large Indigenous Native American population, and so you may be a little bit more familiar with this term than many of us are on the East Coast. And that is something called 2S or Two-Spirit, which in many Native American cultures and other Indigenous cultures around the world is culturally considered a third gender. You will also, there is also evidence of this in not just Native American cultures, but in different cultures around the world. There in some of the Asian cultures, there is this designation of actually a third gender category that is a completely different gender. And in many cultures, individuals in this category are revered for spiritual reasons. And so this is another terminology that when you see it, know that this is a culturally designated or culturally identified third gender. Sorry, finding my cursor here. Now, affectional orientation. This is probably my most favorite or favoritist, my favorite word, my favoritist word. This is probably the change that in language that I think I'm most excited about is this change of sexual orientation to affectional orientation. Doesn't take much to excite me. I'm kind of a nerd. But you may understand why when I talk about this a little bit more, because I think it helps to move beyond those intimate relationships that people have, move past just the sexual aspect of intimate relationships and romantic relationships. Because anybody who's been in a good, healthy romantic relationship knows it's not just about sex. And very often that's just a part of it, right? Maybe it's more important to some than to others, but that's just one part of it. So when we talk about affectional orientation, it's a newer term for sexual orientation. And it kind of takes two aspects of what happens when we start to feel something for another individual, a romantic feeling and which leads to desire. So that is, it takes into consideration our affect, how we feel when we think about the person, when we see the person, when we interact with them, when we hear their voice, right? So those things that it does to us effectually, meaning how we feel and then express ourselves, and our cognitions, how we think about ourselves in relation to that person. Do we feel valued? Do we feel like they desire us? And I don't just mean sexual desire, but they want to share space with us. They want to share our time. And I think that these are things that we want our service recipients to experience. I know I want that for me, and I want that for all of us. And we definitely want our service recipients to be in the place where they can have that healthy and beneficial experience. So it's this combination of how we feel in relation to that person and how we think about not only ourselves, but that person that increases or that contributes to desire for another individual. And that is what we call affectual orientation. So again, not just about sex. Some people may refer to it as romantic orientation. I don't necessarily have a problem with that because, again, romance is bigger than sex alone, right? And one's orientation is defined by who an individual is predisposed. I don't know if that's the best term, but that is the definitional term to fall in love with. Sexual attraction being only one part of a larger dynamic. So there's things like how we feel, how we think around the person, being also a part of that, and probably larger parts than sex alone. Okay. So some terms that fall under the affectional orientation, or what would have previously been called sexual orientation umbrella, are things like straight. And I hate that term. I never realized how much I hate that term until I got older and really started learning more about this stuff, because to me, straight denotes correct. At least it's a loaded term for me, and I don't think that there's a correctness to one's affectional orientation or an incorrectness. That's, as long as everybody's consenting and we're all adults, right? So I think that can be it could be a dangerous term. At least I feel it is. But again, we want to go with terminology that people understand and identify with, right? So when we talk a little bit later about how to ask questions, how to talk to an individual who you think may be experiencing some stress or some stigma, or maybe some internalized stigma, or some sort of dysphoria related to how they're feeling, we want to be able to use the terminology that they feel comfortable with. And we'll talk a little bit about how we can encourage people to use their own language, and then we can go with that. Gay or lesbian, so individuals who are attracted to members of the same sex. Bisexual, so individuals who may be attracted to people of the same sex and the opposite sex. Pansexual or polyamorous. People tend to use these terms interchangeably when talking about a group of people who can experience sexuality with or have sexual feelings and or love with people of a variety of genders, right? So one of the reasons why I put both of these here is that there may be individuals who consider themselves pansexual who may not consider themselves polyamorous, depending upon how they define that term, right? So if you see polyamorous, the term amour is there, love, right? So some people may find it possible and satisfying to have sex with people of the same biological sex, and sex with people of what we would consider the opposite biological sex, but not be in love with multiple people at the same time, right? Whereas others can. And again, can't judge that. It's for one person to, it's for the individual to experience. But I just want you to understand some of the nuances, some of the overlap with the terms, and where sometimes it can be confused, and why we should ask people if we have a service recipient who says, I identify as polyamorous. What does that mean to you? Can you tell me what that means to you? Right? So it may mean that they're in love with a couple people at the same time. To them, it may mean that they're able to have sex with concurrent partners. So finding out what the individual means is important. And we also include individuals who may identify as asexual here. So there are individuals who may be asexual by choice for, for long periods of time or for shorter periods of time. This is not necessarily the same as being celibate. So being asexual is more aligned with not experiencing desire, the sexual desire for others. And other people may say it's simply not acting on the sexual desire. But most people in the field talk about being asexual as not having that desire or feeling of need for sexual expression with others.
Dawn, there's a couple
Yes,
comments
ma'am.
that came in about pan and poly, not really related. Okay, pan and poly are not related. Pansexual means attraction to people like not based on gender or sex at all, and poly means being able to be in a relationship with multiple people at once. And so
Right.
It's not like pan, and then Alyssa described pan as being attracted to the person, not their packaging, she said. And she's never heard it explained as someone who is seeking more than one person. So that would be poly, but maybe they just belong in different categories. I think
right. And I think that, go ahead. I'm sorry.
No, go ahead.
No, you go ahead. Go ahead. Go ahead.
I was just gonna say, I think the more important part, and this isn't my area of expertise, but I'm thinking that the more important part, regardless of how we categorize it, and I'm pretty sure that's correct. Like the pan is like all or anyone or whatever.
Yes.
But the idea that you have to ask the person that you're working with, what does that mean to you?
Yeah.
Right. So it might mean something to me the way I define it.
Well, and I like as was it Bailey? Yeah, as Bailey highlighted, there are these, there's absolutely, and I thank you for that, Bailey. There are definitional, I'm gonna say definitional explanations, and then it's our personal kind of impression of what that means to us. Yes.
And I think if you ask a client that you're working with, like or if they've identified as bisexual, like even though we have a predefined idea of what that means to us, like what does it mean to them? Because saying I'm this when they're trying to explain something different. So I think just always getting their idea of what it means to them, so you have a better understanding instead of projecting our predefined ideas of what that word or term means on them.
Yeah, absolutely. And I thank everybody for their contributions. And I love that the experiences in the room, and I truly appreciate that. And based on that feedback, I'll incorporate that, not only like delineate it a bit more. So I appreciate that. And so I'm reading, Chrissy says that asexual includes identities such as demi and aromantic as well. Absolutely. And demisexual being only sexually attracted once one is emotionally attracted, and aromantic, not experiencing romantic attraction. So these are kind of like catchment words. And I absolutely encourage you. And there's going to be a list of resources at the end of this where you can actually get more terms that are included in many in these categories. Thank you. So one of the things I have here is a lot of asterisks, right? So I feel like some of the terms haven't caught up yet. In terms of, we see things like this, these kind of umbrella terms like bisexual, heterosexual, homosexual, and we know that sex isn't the only part of that equation, right? So I don't know if we're ever going to see an evolution in those terminologies. Maybe, I don't know. But again, what the individual identifies as, how they define their relationship, and it may not, or I shouldn't say relationship, but who they are attracted to, may not be confined to one word, right? It may be, but an individual, let's give them the opportunity to express that. Sorry, looking for my cursor again. It always disappears in Zoom. So, Jen, can I have a time check?
Yeah, it's 5:55. So we
Oh,
have 35
okay.
minutes.
So I'm doing okay tonight. So let's talk a little bit about, make that transition to kind of some of the talk that we can use in order to elicit information from individuals when we're talking to them about some of their unmet needs, which may include sexual health unmet needs. So at this point, we're not just talking about, we're not limiting this to a conversation about gender identity or affectual orientation, but other unmet needs that may fall within that umbrella of sexual health. As with any unmet need, our approach is the same, right? So we want to ask questions, we want to be inquisitive, we want to find out about people and provide them with that positive and safe space, just as we would at any time, in letting them tell us their story, allowing them to clarify their needs and what some of their goals are and what they see for themselves, and allow us the opportunity to maybe observe that and assist them with that. To establish goals, to obviously educate or link to services, which I think probably a lot of people in this room, I know I sure did a lot of that, and Jen sure did a lot of that, and to advocate for folks. So these are the things that we're already doing as professionals in the field. It's just really getting a little bit more comfortable around sexual health and then that conversation. So the skill set's already there. We know this. So one of the things that I'm going to advertise here is a free resource, and the link is at the end of the PowerPoint presentation, and you'll receive that you will receive in probably the next 24 hours or so, is this toolkit that you can use to get more comfortable with using motivational interviewing techniques to have conversations around intimacy and sexuality with individuals that you are working with, that you are serving, that you may come in contact with. And this toolkit came out of research and was tested out in populations, case management programs in inner cities, working with individuals vulnerable to HIV/AIDS infection, and primarily targeting individuals with behavioral health conditions, and those who are homeless and at risk of homelessness. So, really working with individuals with a lot of barriers, a lot of, stigma, a lot of challenges to face. So one of the reasons this population was targeted is because individuals with mental health conditions who were also homeless and may be using substances are one of the highest populations at risk for sexually transmitted infections, unintended or unplanned pregnancies, and intimate partner violence. And they also tend to be some of the most underserved in terms of being able to access, sexual health care, including gender affirming and reproductive care. So we want to start any conversation, but especially around what we may feel as difficult conversations, right? They may feel difficult for us. Maybe the individual that we're serving is open to it. But I will say that every time that I talk about sexual health, there's a little bit of nervousness in me. And that's not because I'm uncomfortable, but I know that invariably, and usually it happens when it's more likely in person, I can see discomfort sometimes on people's faces. Or maybe I'm just interpreting that as discomfort because the societal lens has told me we don't talk about this stuff. We shouldn't talk about this stuff, right? And so it's really this practice of finding a medium that will help you have and structure these conversations. It will make you more comfortable and hopefully make your service recipient, service participant more comfortable with engaging with you in that conversation. So we want to start by doing things like using open-ended questions. So there's this acronym called OARS. If you've attended probably any training on counseling, basic counseling techniques, definitely probably motivational interviewing trainings will cover this. You know that we do when we talk about motivational interviewing. But we want to use open-ended questions, affirmations, reflective listening, and summarizing. And so an example of an open-ended question would be, how would you describe yourself in terms of being masculine or feminine, right? We want to try to avoid closed-ended questions. Can somebody give me a flip example of that? What would be a closed-ended question? Closed-ended interpretation of that question, which limits the response.
Right. Like, do you identify as masculine? A yes or no question. Are you male or female? Like,
Yeah.
it has a very distinct, discrete answer.
Yeah, you're limiting it to those two options, right? An individual may not identify with either one, or maybe may identify as gender fluid or, somewhere along this continuum, right? So in any questioning where we're trying to elicit rich information from the individual that we're working with, we don't want to limit them, right? And so we want to offer them options and allow them to elaborate and come up with the explanation. Likewise, tell me about the type of people you're attracted to, right? You might want to say, type of people you're interested in. There might be ways that you can phrase that differently, but tell me about the type of people you're attracted to versus, are you attracted to men or women, right? Tell me a little bit about how you keep yourself safe when you're sexually active with another person. So very different from, do you practice safe sex? Because one of the reasons why that could be a dangerous question is an individual may have an understanding of what they think safe sex is, and it may not be safe at all, right? So we want people to be able to express this, and I highlight in terms of like risk, like that question. We can have a real missed opportunity if we just ask the safe sex question. Catherine's raising her hand, I think. I like that. What's your type?
Yeah,
Okay, Catherine, you're unmuted.
Hi, Catherine.
okay. Yeah, I was just wondering if that was an appropriate way to approach, and as far as questions wise, is that closed-ended? What would you consider that? Me asking, like, for example, what is your type?
So I think you're breaking up a little bit, but I think Catherine's saying if you ask the question, what is your type? Is that closed-ended? Like, does that limit a response?
Yes. That's what
I don't know. What do folks think? I don't think it limits. You may have to elaborate. You might want to, maybe when you're working with somebody, you might have to elaborate on that a little bit. But I think it depends upon, I think that's the other thing that we're probably not talking about that maybe we should, is knowing the individual you're working with too, right? And knowing, not that we want to presume the language that they speak in terms of like expressions and that kind of thing, not actual language, but their expressions that they use. But like, you may know the terminology that your client uses, right? Or that your service participant uses. And so maybe that's an appropriate term to use, but no, I don't think it's a closed-ended question. I think it's better than asking, do you like men or women? It allows people to kind of elaborate a little bit more.
Thank you so much.
You're welcome. Thank you for the question. Yeah, and you know what? I don't get this right all the time, right? We can slip up. And just like sometimes I say, uh, I may use a term that's not person-centered when it comes to talking about people with behavioral health conditions, because I tend to do a lot of consulting work in involuntary environments, right? So using that patient word, which I know is really loaded, I slip up all the time. I know I do. I know I'm far from perfect. So it's about getting comfortable with the language and also understanding the people that you work with, the individuals you work with in the language that they may be comfortable with or more fluent with. And then we have affirmations. So an affirmation is identifying and reflecting back strengths to an individual. So if an individual says, well, yeah, I'd like to be more consistent with using condoms or with using protective barriers, in the case of women, other protective barriers. But like I'm really bad at like forming habits or changing bad habits, right? And this is where you can affirm strengths that the person has, other things that they have accomplished and been able to do. Well, I know it's difficult. It's difficult to change habits. But remember when you did X, Y, and Z, right? And you were able to make progress on that goal or towards that goal. You didn't think you could do that, right? So it's like really kind of, I'm going to say pumping up or hyping up an individual, but really capitalizing on their strengths and seeing if we can use those strengths towards another goal. And again, this isn't specific to sexual health. This can be used, the strategy can be used with any kind of goal or behavior change that an individual may be considering or may not even be contemplating yet. And we're going to talk about that in a minute. Reflective listening. So reflective listening is wonderful, but because it allows us to be really wrong and to get corrected. So reflective listening is as simple as, so if I'm hearing you correctly, it sounds like you have some concerns that perhaps individuals that you're experiencing sexual activity with, maybe there might be some risk there. And you're a little worried about this, but you're not sure if you're ready to, go get tested and perhaps, start using condoms or changing your practices, right? So like it's that reflecting back what you've heard and allowing the individual to correct you if you're wrong. And it's fine if you are, because this is the opportunity for them to course correct you. And then finally, summarizing. So summarizing is more of like a succinct reflection of the entire conversation or time that you spent with the individual, again, allowing for corrections to your understanding. So this is especially important because when we're wrapping up with a person, we're having a conversation about something that might be a particular concern to them, or perhaps something that we're noticing that is concerning to us about maybe their health, their sobriety, their recovery. It allows us to get an understanding of their perception, where their ideas are in terms of where they want to go, and how we might be able to support them and what their agreement level is in participating or accepting that support. Okay. It's a lot of words on this slide, and it's purposeful so that you have it, not just so that I can read off of it. But I wanted to provide you with some examples of things called stages of change. And I'm sure that most of you have probably heard about Prochaska and DiClementi's seminal work in Stages of Change. And the idea about stages of change in a nutshell is that we are all typically can be in different places around behaviors that we are engaging in, habits that we may engage in that are good for us, not so good for us, or really, really bad for us, right? And some of these habits, I'm sure we're aware of. I think I'm aware of pretty much 99% of my bad ones, but I'm sure people around me could sure tell me a few more that need to change. But we may be also at different places in terms of our readiness to make change. around towards more healthy lifestyles, towards more healthy behaviors. So I could be eating right, on top of my nutrition, right? Getting all my nutritional needs met, and at the same time, smoking a pack a day. I smoke a pack a day. I'm not perfect. So, so on one hand, my endocrinologist might be really, really happy with me because my A1C looks great, my cholesterol looks great, and all this. But what am I doing to my cardiovascular system at the same time, right? So, whereas about 7 years ago, I began this nutritional journey, and still have a ways to go, but made a lot of improvements and have kind of incorporated this balance or this healthy balance into my lifestyle. I'm struggling in this other area that just kind of popped up for me. And maybe because that coping skill of the food is gone now, right? So that's also something that we need to keep in mind when we're interacting with people who may have dependency issues or, other kinds of behaviors that may be risky, is that once those behaviors become addressed and may be eliminated, we have to be aware of some unresolved stuff popping up in other areas if our own coping skills are not really beefed up, and so that we can handle with stress rather than moving towards bad behaviors. So let's just go through these. Pre-contemplation is when we're not considering a change and we may not even be aware, or an individual may not be aware, that the behavior that they're engaging in truly has negative consequences, potentially has risks associated with it, right? So an example of this might be an individual who's sexually active with multiple partners. They may be unaware of the health risks and sexual health of their sexual health status. And when I say that, I mean, like, are they free of infection, or do they have viruses or sexually transmitted infections that need to be addressed? And perhaps they don't use protection. I worked with an individual who acquired HIV while in what she thought was a monogamous relationship. And it was her understanding, what she was taught is that you just had to wash before and after sex. And that is how she thought she was able to protect herself. And she acquired HIV from an individual who she thought she was in a monogamous relationship with, right? She did not have the education and insight at that point in time to be able to protect herself in a way that, she rightfully deserved to be protected. And so somewhere there was a failure along the way, whether it be from parents or society or whoever, in imparting that information. She also had, a significant psychiatric condition. And so the intervention with individuals who may be in the pre-contemplation stage, again, not considering change, maybe unaware of any kind of negative consequences, would be simply to provide information on the current behavior and the associated negative consequences, right? So this is what's happening. This is what you're doing. Here's what could happen. Of course, we don't want to like throw it in people's faces and be obnoxious, because we always want to maintain the therapeutic rapport, a positive therapeutic rapport, because if we don't have that, everything else is going to fall apart. So again, the individuals that you work with, that you partner with better than me. And so you want to provide information and education, but at a rate and at a level that the individual can acquire and it finds accessible. Because we also don't want to alienate folks that we're trying to assist. Contemplation. So in the contemplation stage, individuals are aware of some of the pros and cons of their current behavior or feelings, but they might not be ready to take action, right? So for me, I know smoking's not good for me. I smoked before. I quit in 2002. Didn't smoke for 20 years. Life events happened, started smoking. Probably if it were about 15 years ago, I probably would have turned to food, but that's not my coping mechanism anymore. Apparently right now I'm using cigarettes, right? As part of that toolkit, which isn't so healthy. So I would say for my situation, I fall in that contemplation stage where it comes to cigarettes. I know they're bad for me. I almost have my PhD in health science. I should know this stuff. I should be the poster child for not smoking, right? But that's not dissuading me from smoking because it's meeting some kind of need. And so for an individual who is in this stage, it's really important to look at what are the things that are maintaining your bad habit. For me, I do consider it a bad habit of smoking, knowing all the potential consequences, knowing the people in my family who died from cardiovascular disease and stroke, right? So understanding that there are cons of doing this, but there are also some pros. Pro for me that I would highlight for smoking is, oh, it's something to do when I'm bored or when I'm feeling anxious. It's something that I could do really quickly that alleviates that anxiety, when in reality, all it's alleviating is the jonesing for the nicotine. But I digress. But this is how we rationalize, right? So it's an individual who can identify those pros and cons. In this case, example of unprotected sex, they may be well aware, but they might not be ready to change for whatever reason. There are individuals who say that, it robs them of intimacy, or for individuals who might have certain psychiatric conditions who are prescribed medications that may have negative sexual side effects like arousal issues, inability to complete or orgasm. Individuals may say that they feel as if the use of condoms or other protective measures deaden that sensation even more that they're already struggling with. And so these are things that we need to understand, that individuals who are prescribed psychotropic medications, psychiatric medications, may also struggle with more than the general population of people who may not be taking such medications. So we want to, in this case, amplify the ambivalence. So you've identified pros, you've identified cons, you have certain goals for yourself. And this is when it's really awesome to look at the person's other goals that they may be working towards in their life. So, you've said, Joe, John, whatever, that seeing your daughter grow up is really important to you. But any kind of risky behavior can impact your health, right? And your longevity. And I couldn't fit it all in the box, but your ability to see that goal to fruition, to see your daughter graduate, to see your daughter grow up. So we want to kind of like, sometimes I say it's cheating a little bit, but like really pump up those things that the person wants and kind of like poke holes at how this other behavior could get in the way of doing that. So it's highlighting and really amplifying that ambivalence to hopefully tip the scales towards more healthy behavior or the behavior change. In preparation stage, an individual's decided to make the plan. So, the person says, you know what? All right, maybe I should get tested. I'm a little scared, but I'll go get tested and I'll use condoms or I'll use protection until I find out what that test comes back as, right? So, well, keep other people safe until I know I'm clean, right? It's something, it's movement in the right direction. So let's go with that. What you start to see then is this movement towards commitment, and we want to help strengthen that commitment, even if it's incrementally, even if the person just said, yeah, I think I'll take a sexual health screen. I'll take a battery of tests, but they haven't committed to when or where yet. That's some commitment, and we want to continue to kind of strengthen that. So we want to identify options. Well, great. You know what? In some cases, you could do that from your home. In other cases, we might be able to go to your primary medical provider. We could go to a clinic if you'd rather go somewhere where maybe you're a little bit, you don't know people. Identifying what those options are for the individual to kind of reduce the barriers that they're going to face or the anticipated barriers in achieving it. Because sometimes for some individuals, the anxiety might be around what they're going to face in achieving that thing, right? So we want to be there to advocate, to support them, refer, link to other services, and continue to kind of like manage and coordinate. Action is when the individual is currently addressing the plan. So which might include, attending or seeing a specialist. It may mean going to get that test or engage in sexual health counseling, and actively using safer sex practices. So we want to acknowledge that any change is difficult in terms of what you can do as a provider at this stage. We want to celebrate that change, and we want to continue to support people with execution of their plan. I will say, I had an instance where I worked at a faith-based organization for all of 4 months. It wasn't a good fit. And it's not a knock against faith-based organizations. I think it was just how this one in particular was kind of managed, right? And they were very adherent to their faith and to the mission. And we had a couple of ladies who were in our residential care and group homes who were actively engaging in sex with some of the gentlemen in our male group home. Some of the gentlemen, not only were the ladies and gentlemen having unprotected sex, these were individuals who were in some other additional high-risk categories, including previous intravenous drug use, right? And so I became very alarmed, very, very, very alarmed. And I was a headstrong 24, 25-year-old. And I said, oh, no, ladies, we're going to the clinic. We're going to the clinic, and we're getting tested. And they were on board. Like, they wanted this. They wanted to get condoms. They wanted to empower themselves. We were Wonder Womaning it up, and we were marching in there. We were getting our sexual health needs met. I even said to them, if it makes you feel better, I'll get tested too. We went to the county health clinic to show, like, we can do this, right? And I got in trouble for taking them for reproductive care, what was considered reproductive care. And so I say this, support is really, really important, because we do not know what kind of messages individuals are being sent. We do not know if they have support in other areas. In my circumstance, I found it really upsetting to me that an organization wouldn't support whole health, just because it was inconvenient to their beliefs. And so we don't know in terms of like the support systems that people have in their families, their primary supports, people that they consider friends, what those support structures look like. And so it's really important that we connect with people at this point to find out from them specifically what it is that we can do to help support their plan, to help support the longevity of this positive behavioral change, and actively advocate for them when you feel as if systemically I feel they're being discriminated against. And maintenance. So maintenance is when a new behavior is established and maintained. So this is when typically people talk about, and there may be folks in here who have experience with other substance use recovery communities and programming. I think that they talk about 6 months, a behavior kind of becomes ingrained. Some people say it's like 3 months. It moves all over the place, but there may be different terminology in terms of when we look at, substance abuse or substance dependence type programming versus other programming or versus other areas that we might be working on. But generally, this is when the new behavior has become established, maintained. We don't think about it as much. We may occasionally slip up, but it's not an intentional thing. So this looks like an individual may be getting tested annually, maybe every 6 months for the first year or two, then tested annually after that, and using protection. And maybe it also looks like when that person's situation changes, what then does the plan need to be amended at all? Let's say an individual's in a monogamous relationship. What does that look like? Do they continue using protection? Do they eventually not use it? These are all conversations that we should be able to empower people to have with their partners. And that could take practice and assistance in helping them, communicate those kinds of concerns and and conversations with their significant others. So this is where we evaluate the present behavior. We revisit the plan as needed. And again, like I said, things can change. Things can change. So if a person's relationship status changes, or if they change who they're engaging with, then, you know, things may look differently for them. Okay, there's a lot of information on that slide, but I wanted you guys to have that to take with you. So this slide was also included in last week's presentation. These are some recommendations for additional information. Individuals who were participating earlier highlighted some additional terms like aromantic, agender, that may be also incorporated into some of the broader umbrella terms that we use today. When you go to these websites, if you decide to go to any of these resources, you will see much more in depth, much more than we could talk about and cover in, you know, 75 or 90 minutes here today. So we have the American Sexual Health Association, the American Public Health Association, which has much more information even beyond sexual health, but they have a really nice sexual health section. The Centers for Disease Control and Prevention have a lot of nice, clear information and toolkits and things of this nature that you can utilize with people that you work with. And I think it's part of the ASHA, which is the American Sexual Health Association. They have something called Sexual Health TV. That's an assortment of videos that you can watch for more education and tips on having challenging conversations. So I'm going to go ahead and pause there. Thank you, Oliver. Not a problem. Take care, Oliver. Good luck at your next meeting. So I want to pause there and find out if anybody has any questions or comments or things that they want to add to the conversation at this point. And I want to thank you all for being really participatory and talking and sharing your experience and your knowledge. Again, I am still learning. And I think that, you know, being willing to say that and accept everybody's contributions is what makes conversations around this topic so rich and I think rewarding, at least for me. Don't see anything. So while we wait to see if there's any questions, I want to go ahead and read this slide, another housekeeping item. We want to thank you for attending today. We appreciate your time, attention, and participation. And today's webinar was hosted by DBHR through the Healthcare Authority. So we'd like to remind all of you that the slides, a link to the recording of the session, and any associated resources will be available in the follow-up email. And don't forget to check out the Foundational Community Supports newsletter for all things FCS and upcoming training events. And if you're interested in becoming a Foundational Community Support provider, please reach out to AmeriGroup at the number listed. That's our commercial for FCS and the state of Washington, which we love very much. There's also a free online resource. And Jen, I don't know if you already put it in the chat, if you would be willing to put that in the chat. Jen was going to put a link to our groups, our little work group, the State Hospital Psychiatric Rehabilitation Initiatives website. When you land at this website, you can click on trainings or free online trainings and find a wealth of free information there and videos on a variety of topics. So we welcome you to use that as a resource for yourself and for others you might work with. Thanks, Jen.
Sure.
Thank you, Chrissy. I really appreciate that. And I accept any and all feedback. If any of the language that I used was not inclusive, I'm striving to be more inclusive, and I appreciate your feedback. I really do. Thank you. Thank you, Roseanne. I appreciate it. Oh, I look so dark now. What happened?
You closed the share screen, I think. Have a good night, everybody. Thanks so much.
Bye, all. Take care.
Thank you.